All right, listen up. The clock's ticking. Mitral regurgitation. Let's hit it fast.
Focus. Mitral regurgitation is a volume problem, period. The heart is drowning in backflow. It's that simple.
Your classic sign? A high-pitched, holosystolic murmur. Lasts the whole contraction. Hear it at the apex, radiates straight to the axilla. Apex to axilla. Got it?
Acute MR? Think papillary muscle rupture post-MI. Your patient is in cardiogenic shock, flash pulmonary edema. It's a total catastrophe.
Chronic MR? That's a different story. Maybe mitral valve prolapse or rheumatic fever. Here, the heart's had time to adapt. It stretches, it dilates, it tries to cope.
Your treatment? Afterload reduction. AC inhibitors are your go-to. Ease that strain. Let's go. Before we proceed any further, I must state a mandatory disclaimer. The information presented here is intended for educational and board review purposes only. It is not, under any circumstances, to be considered medical advice. You must always consult official clinical guidelines and a qualified supervising physician for patient care. All right, so let's dig into a question that always comes up. We keep saying the axilla, but why? Why does the murmur from mitral regurgitation travel there of all places? Well, it's all about anatomy. It's physics, really. The direction of that regurgitant jet. You see, the mitral valve is situated posteriorly in the heart. So when that blood leaks backward, the jet is aimed right for the left armpit. It's a straight shot. That's why when you're listening and you hear that murmur getting louder as you slide your stethoscope over to the axilla, you've basically confirmed your suspicion. That's mitral regurgitation. Okay, and I have to pause here because this is absolutely critical. In the description below, you will find the resources and guidelines. I've linked the 2021 ESC and the 2020 AHA guidelines. Think of these as the rulebook. They are not optional reading. They tell you exactly when an ejection fraction is too low to just watch and. So here's a really important concept to grasp. Mitral regurgitation isn't just one thing. It's actually two totally different stories, two completely different clinical paths. You have the acute emergency and you have the chronic problem. And this slide just lays it all out, the stark contrast between the two. Look, acute MR, it's a nightmare scenario. A papillary muscle just snaps post-heart attack. And the left atrium, it's completely, utterly unprepared for that insane sudden volume overload. So what happens? Pressure goes through the roof, blood backs up into the lungs, and boom, flash pulmonary edema. That patient needs the OR like yesterday. Now, chronic MR is different. The atrium has had years, maybe decades, to stretch and adapt. But here is a clinical pearl you cannot forget. In that acute catastrophic setting, the murmur can be quiet, even absent. Why? Because the pressure is equalized so fast. So please, do not be reassured by a quiet murmur in a patient who is crashing right in front of you. Okay, which brings us to it. The single most important number you need to know from the guidelines for managing severe chronic MR. Here it is, 60%. An ejection fraction below 60% for a patient with severe chronic MR who feels fine, who's asymptomatic. If that EF drops below 60%, you pick up the phone and you call a surgeon. That is the trigger. You do not wait. All right, let's lock all of this in. We're going to burn it into memory with a little chant. Ready? Let's do it. Apex to axilla. Holosystolic is the blow. Acute is the rupture. Chronic is the dilation. And the last one, links, review, don't forget those guidelines. And that leads us perfectly to our question of the day, something to really chew on. In mitral regurgitation, does the loudness of that murmur always tell you how bad the leak is? Think about it and drop your answer in the comments below. Great work! We've tackled the backflow problem head on. But what happens when the valve isn't leaky, but it's stuck shut? What happens when it won't open? Well, that's what we're diving into next time as we take on aortic stenosis.